Okay, thank you for coming. Sorry for the short notice. Okay, so I will be a little bit quick because I am expected to present that presentation in 20 minutes. Okay, okay, guys, and it's an adult conference, so all the cases are adult cases, but they are relevant to us. Okay, okay. So I apologize in advance for being quick, but and you can interrupt me if you have any questions, okay? And I will skip the management any piece of the talk because it's beyond the scope of this presentation. Okay, okay, guys. For case one, 26 years old, who was pregnant for 2 months. Sorry, was delivered 2 months ago, and she had recurrent syncope. She mainly when her alarm goes off or when her child, newborn, wakes her up from sleep, and with family history of significant sudden cardiac death. Okay. Um, we want to be quick, guys. Anything obvious on the CCG? Just speak up.
It looks long QT.
Okay, repolarization is very abnormal or very long. Okay, حلو. انزين فشي actually was
There's
admitted.
prominent U wave.
Okay, فشي was admitted to Amiri Hospital, and like we said, طبعا just a quick hint, if the T wave is beyond 50% of the RR interval, then you have to measure it carefully, but might very likely be measured, long. Okay, but I can discuss. Okay, عموما. ف, and then she was admitted to Amiri hospital, and she was doing polymorphic ventricular tachycardia while being admitted. And this probably explains why she was having fainting episodes at home. And then also her echo was showing decreased cardiac function, probably because of frequent polymorphic ventricular tachycardia. Okay, so it's an unusual case. So when you encounter such a case, obviously you note immediately there's long QT syndrome, and then you have two main differential, congenital or acquired. Okay, but there are so many acquired causes for long QT interval, and then they were mostly ruled out. Plus, طبعا, in her case, there is positive family history, but this suggests congenital in nature. And but obviously you want to make sure there's no acquired cause that I would not go into. Okay, but طبعا, long story short, we did genetic testing, and it was positive for long QT type 2, and which explains her phenotype. Okay. Just really quick, for the congenital type, in order to diagnose a long QT syndrome patient, there is a score that the patient you can use, and if the patient scores above or equal to 3.5 on that score, and I'll show you the score in a second, then this meets criteria for long QT syndrome diagnosis. Or if you have a pathogenic mutation in one of the known long QT genes, or if the QTC interval is above 500, but unexplained, and without acquired cause. Okay, and or if the QTC is between 480 and 499 with unexplained syncope. And there are criteria to diagnose long QT syndrome, but in our patient, she met multiple, and she met almost all these criteria. Okay, that's a Schwartz score that you may want to look up whenever you encounter a patient with long QT syndrome. I will be quick here because so many slides and I want to be done within 30 minutes, okay? And we did discuss this in the past, so I will not go into details, okay? So in brief, long QT syndrome is actually not very, very rare. It is like, you can think of it similar to SLE patients in terms of prevalence, okay? But it's challenging because the QTC may or may not be prolonged during the ECG that you obtain in clinic, okay? So there's penetrance, incomplete penetrance, and hence when you have a patient with long QT syndrome, established patient with long QT syndrome, gene positive long QT syndrome patient, you want to screen the family members at risk with that genetic testing instead of doing ECG screening, because ECG screening the ECG may be normal, like looks normal, but the patient in fact has the gene. So don't rely on only ECG screening if there is a positive gene mutation in that family. Okay. For adults, you the cutoff values in terms of prolonged QTC intervals are 480 for females and 470 for males. And in there are many long QT genes, and these are the most common long QT genes that are known. Okay, and like we said, genetic testing is very high yield for long QT syndrome patient. Roughly 80% of long QT syndrome patients will have a positive genetic testing. The genetic testing is very high yield, and you should do it whenever you have high suspicion for long QT syndrome in a patient. Okay. Okay, so this is case 2. 22 years old, recurrent syncope, family history of sudden cardiac death. 2 siblings actually died, and she's deaf. She's a product of consanguineous marriage, and she has seizures for 20 years now, like almost when she was like 2 to 3 years of age. So her story is interesting. She also had, she fainted so many times. At some point, someone decided to do echo or cardiac evaluation without recognizing any specific abnormalities. So when they did the echo and they did the ECG, the echo showed also cardiac dysfunction, like there's decreased LV function. So she went for cardiac MRI, but during the cardiac MRI, the anesthesiologist, who was actually Abdulaziz Lassaimi, he's not anesthesiologist, but he was intubating patients in the MRI suite, recognized the ECG and phoned me, and he was like, this patient is deaf, has sudden cardiac death family history. His ECG is as such. I'm not sure why MRI is needed. You should probably see this patient. So what do you guys think Abdulaziz was thinking of?
It's also long QT, maybe Roman-Ward syndrome.
Jervell Lange-Nielsen.
Oh,
Yeah.
Jervell Lange-Nielsen. Okay.
Yeah, so Romano ward is like long QT syndrome without deafness, okay?
Without deafness, yes, without. Okay.
Yeah. So yes, so Abdulaziz was very smart and recognized that and phoned me, and then we canceled the MRI. We did see the patient. We suspected Jervell Lange-Nielsen syndrome. We confirmed it by genetic testing, and her function normalized after we gave her appropriate medications, and she stopped having seizures. Okay. So that's a true story. This just happened last year in Kuwait. Okay, these are all our patients. Okay. Okay. So obviously the QTC is prolonged. And again, like we said, for long QT syndrome, mostly is inherited in an autosomal dominant pattern, which is also called Romano-Ward syndrome. But there are less commonly inherited forms of long QT syndrome, inherited as an autosomal recessive pattern, which is, if it's associated with hearing deficits, this is called Jervell and Lange-Nielsen syndrome. Okay, so this was a patient that has had Jervell and Lange-Nielsen syndrome. Okay, so we confirmed homozygous mutation in long QT type 1, and hence the diagnosis, and we canceled her anti-epileptic medications, and she's doing, okay. So just really quick, more further information about long QT syndrome. Like we said, the cutoff for adults 470 and 480, depending whether males or females, and for pediatrics we usually use the cutoff of 460. Okay, but just so you know, so this graph, the one underneath, is for 500 plus patients of established long QT syndrome at Mayo Clinic. Okay, so as you can see, their QT values in clinic ranged from 360 all the way to 760. So there are many patients with long QT syndrome, gene positive long QT syndrome, that, like in clinic at least, would have QTC values, before 480 or 470. Okay, so many of the patients would demonstrate normalish looking ECG, but they still have the long QT syndrome. So you have to be careful with ECG assessment. Okay, so there are many concealed long QT syndromes, like roughly 40% of the cohort at Mayo Clinic were actually concealed, okay, or hidden. Okay, and the average QTC among that cohort was 482. Okay. So again, just measuring QTC value is not enough. You have to look at the repolarization morphology, you have to take good family history, you may need to do exercise stress tests, and so forth. Okay, and then like we said, history is very important. If someone presented with mid-exertional syncope, auditory syncope, postpartum syncope, this might be very well malignant. So you want to be careful with such history. Okay, and then pregnancy, post-pregnancy syncopes also might be very important. Okay, okay. So that first case, if you remember, presented with that ECG. You see my pointer, right? Presented with this ECG, if you remember, okay? But then after time, when she stabilized, you know, postpartum period went away, she's on medication therapy. This is her current ECG, you know, has long QT syndrome. This is, huh, guys? Right? It looks very normal, right? But like we said, the QT value might progress, might normalize depending on the patient status, okay? Depending on multiple factors. Agree, guys? Okay, so that's the same patient, okay? This is postpartum, pregnancy, postpartum ECG, and this is, you know, like recent ECG, okay? Okay, same
The
patient.
slide disappeared, Mohammed. We can
Yeah.
only see you.
Oh, oh, sorry. So you cannot see me anymore? Okay. What happened? Okay. Okay, sorry. You can see me now? You can see me?
Yes, 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 yes. We
Okay.
can see the screen.
Right?
Yes.
Okay. I don't know what happened. Okay. Anyway, so that is the same patient now versus the same patient postpartum. You see the QTC, how different it is. Okay. So so it's very variable. Okay. Anyways. Okay. Okay. So for these two cases, which which I just presented, I presented long QT type 1 and Jervell Lange, sorry, long QT type 2, first case, and second case was Jervell Lange-Nielsen syndrome. So they, so for long QT syndrome, it's the commonest channelopathy, and then in our region, it's probably much more common than in the US. It is definitely challenging to diagnose because the QTC value might alternate. Okay, and then genetic testing for at-risk individuals is a must. Okay, if you have a positive established gene positive mutation for that family. Okay, okay. So let's proceed. Okay, and then if you want more details about long QT syndrome, we do have a presentation for long QT syndrome. Okay, okay. So case 3. So this is a patient who was presented when he was 14 years of age with cardiac arrest while having an argument. Okay, and then he had a normal echo, normal CTE. He was asthmatic, so someone decided to give beta blockers, but without knowing exactly the diagnosis. But because of his severe asthma, beta blocker was not even started. So he was left untreated, but had repeated syncopal episodes. At some point, when he was 16 years of age, transvenous ICD was implanted, and he had multiple appropriate shocks while mainly swimming or when he was upset. Okay, he then quitted swimming and he became largely asymptomatic. He had multiple family history of sudden cardiac death, mainly when dancing, being upset, scared during soccer and so forth. Okay, and then he's a product of non-consanguineous marriage. Okay, so this was his ECG. So they referred this patient to me because he has now 2 kids, and his diagnosis was idiopathic VT at the time, or VF at the time, and then they want me to just screen for any arrhythmias for his 2 kids. Okay, so I met the family. This family history is very interesting. So I examined dad, or I did ECG for dad. This was his ECG, and then I, because of stress-induced arrhythmias, obviously, I wanted to do also exercise stress test. Okay, but in general, with his resting ECG, there's no QTC prolongation, there's no Brugada pattern, there's no ectopy, there is no short QT syndrome, there is no WW, there's nothing that might explain his arrest. Okay, nothing obvious at least. Okay, so next we do a stress test. Like we said, echo was normal, and during stress test, he had multiple ventricular ectopy and with polymorphic, right? You guys, can you see that, guys? Okay.
Yes. Yes.
Okay, so he had multiple polymorphic ventricular ectopy at peak exercise. Okay, طبعا we do specific exercise protocol for such patients, but long story short, he had multiple ventricular activity at peak exercise, which is very abnormal. Okay, so what do you guys think might be the reason for this family multiple cardiac arrests?
CPVT.
Yeah. Okay. So this is very diagnostic for CPVT, catecholaminergic by polymorphic ventricular tachycardia, and he had, again, like I said, move. Okay. زين متولي, you can hear me now?
ايوه ايوه سامع.
زين, we have to probably resume. الحين اخترب شلون قاعد اسجل الحين, يصير امسح الجزء هذا؟
بتهيألي هو هتطلع في التسجيل اكيد.
اي بس لازم امسحها صح؟ شلون امسحها؟
ممكن تعمل تريمنج للفيديو بعد ما بتسجل، لو هو في الاخر قبل ما تحطه على اليوتيوب ولا اي حاجه ممكن تعمل له تريمنج، تشيل جزء كبير منه.
اوكي.
واو.
زين.
يبقى في
محمد
اوبشن
شو اللي
تريمنج.
صار تو؟
هذا اول مره اول مره يصير في شيء كذي يعني.
والله محمد انا لازم ما تلومني اني انا ماي محاضرات في اليوم ورايح
انت
لك.
قبسه اول مره تحضر وش اسمه. زين عموما زين الناس قاعد ترجع. اوكي زين. اوكي anyways okay okay so the differential diagnosis is يعني he had exertional emotional arrhythmias طبعا, ف CPVT is very high should be high on your differential plus long QT syndrome. okay زين, فطبعا his exercise stress test confirmed CPVT, there's no repolarization abnormality, so CPVT for this case until proven otherwise. Genetic testing confirmed CPVT diagnoses with positive gene mutation. Okay, or ryanodine receptor mutation. Okay, so really quick for CPVT, the prevalence is largely unknown, but يعني it's definitely less common than long QT syndrome. And this is why it's important to do stress test during for any patient with unexplained cardiac arrest or fainting, okay? Especially with exercise or with emotion, okay? Okay, and for the diagnostic arrhythmia for CPVT is bidirectional, okay? And so you want to remember that for CPVT, ECG is normal at presentation or at rest, but then there's polymorphicity during high catecholamine surge, okay? So you need specific exercise just as protocol, and the penalty is very high, meaning for these two, so for this family, like we said, he has 2 kids, and then yes, they were asymptomatic at the time, but because it's very malignant, it's with high penetrance, we often treat them whenever we encounter the patients, okay? Okay, anyway, so for cardiac, for anyone with arrest with syncope unexplained, you want to do with positive family history, obviously, part of your work would be ECG imaging, stress test, and then for these couple of cases that we just presented, channelopathy was very highly suspicious because the imaging were normal, except for decreased function because of frequent arrhythmias, but the imaging was otherwise normal. And there's positive family history of sudden cardiac death, otherwise unexplained. So you have to be suspicious of channelopathy, and long QT syndrome, CPVT is among channelopathies. Okay. Okay. So case 4, 16 years old with palpitations, negative family history, non-consanguineous parents. Okay. What do you guys see on the ECG?
T-wave inversion in lateral leads.
Yeah, there is high voltage bilateral lead with T-wave inversion or like strain pattern, okay? Okay, so there is LVH on the ECG. The echo and MRI confirmed HCM with scar, and there was no hypertension or valve disease that explains her HCM. She's only 16 years of age. Holter showed few PVCs. So when you have unexplained HCM, genetic testing is a standard of care. So we did genetic testing, and there was LAMP2 mutation, which was pathogenic. So the parents were both negative. So this 16 years old individual had de novo mutation in LAMP2 gene, which causes something called Danon disease. So what is Danon disease? Is an X-linked dominant metabolic disorder. So hence it's more aggressive in men, which results in cardiomyopathy, mainly hypertrophic cardiomyopathy, and might, some intellectual disability, but it usually presents with severe hypertrophic cardiomyopathy. So in addition to hypertrophic cardiomyopathy, they like expected, they might have heart failure symptoms and arrhythmia symptoms. The LAMP, so what happens in these individuals, there is an issue, or the cells are unable to get rid of aged cellular contents. So the aged cellular contents are accumulated within the cells, and results in hypertrophic cells or enlarged cells and extreme hypertrophic cardiomyopathy. Okay. Okay, so remember, whenever you encounter HCM patient, unexplained, meaning there's no valve disease, there's no hypertension, then you need to do genetic testing, okay? And this is a very rare cause of genetic testing, of hypertrophic cardiomyopathy, and this is our first patient Kuwait. And if you want to know more about Danon cardiomyopathy, so we have a presentation in our YouTube that details further Danon cardiomyopathy. Okay, so case 5. 34 years old, female, who had cardiac screening because her 11 years old sister died suddenly, okay? She had non-sustained VT on Holter monitoring. She had an echo which showed mildly dilated left ventricle, EF around 43%. She had MRI confirming the dilation and mild decreased function with scarring in her LV. Okay, so she had a couple of ECGs. These are examples of her ECGs. What do you guys see? Yeah, nothing very remarkable, but what do you guys see, obviously?
Long QT.
Long QT. I mean, the T waves are flat. Yeah, I mean, yeah, maybe it looks a little bit generous. What else do you see?
BVC.
PVCs, okay? PVCs, they are different in morphology. For example, so this is assuming this lead and this are the same. They are the same. So this looks like negative, this looks positive. So there's different PVCs. Voltage is a little bit on the lower side. QTC, well, might measure a little bit long. Okay. So, but يعني, you know, like we said, long QT syndrome generally have a normal MRI, normal echo. There's no scarring in the left ventricle, right, Adnan? The scarring in the left ventricle is against long QT syndrome, right? You agree, Adnan? Okay. Okay. So the 11 years old sister died. Like we said, she had a couple of cousins who died as well. And not necessarily during activity, just depends. So we have a patient who's young with LV scar, dilation of the ventricles, positive family history, unexplained. So obviously we do genetic testing as well. Okay. So we did genetic testing. It came back positive for desmoplakin gene mutation, which is a desmosomal protein that functions in that functions in like cell to cell. It's an adhesive protein for cell to cell for cardiac myocytes, meaning, and this is one cardiac myocytes, this one cardiac myocyte. These are proteins that make them stick together, that makes them be firm together. Okay. The mutations in desmosomal proteins, which are a group of proteins that make cells stick together again, would result in weakening of that connection and weakening of that connection, resulting in scarring and muscle death. Okay, so again, so desmosomal proteins just make the cells like together, and when you have desmosomal protein mutation, the cell to cell junction just falls apart. Okay, so when this happens, there's obviously issues with muscle with muscle function and electrical instability as well. So when you have desmosomal protein mutations, you will have mainly electrical disease plus muscle disease. Okay, and in broad, this is called arrhythmogenic cardiomyopathy, in which you have a patient with muscle disease unexplained, and not because of ischemia, not because of hypertension, not because of valve disease, with predominant scarring and arrhythmias. Okay, and so this is in broad term for such group of diseases. Is arrhythmogenic cardiomyopathy. Okay, so desmoplakin is an example of arrhythmogenic cardiomyopathy, which we do have multiple families with desmoplakin mutations in Kuwait. We have like 4 or 5 at least families, and they are usually not very benignish. They have a couple of sudden cardiac death in the families. Okay. Anyways, so case 6. So this is a pedigree of a family that I encountered relatively recently. I mean, probably a year or so. And then because this family is so large, that pedigree is like circular. Have you ever seen such a pedigree, guys? Like it's very, it's a nice way of presenting pedigree for large families. Anyway, so this family, as you can see, has multiple cases of dilated cardiomyopathy, mainly, and multiple cases of sudden cardiac death. Okay, if you count sudden cardiac death, I think there was 13 family members sudden cardiac death. and dilated cardiomyopathies, many. Okay, so again, there's muscle disease, electrical disease as well. So suspicion for arrhythmogenic cardiomyopathy. Okay. Okay.
ألو وعليكم السلام. أيوة.
Okay. Manal is mute. Okay.
لحظة واحدة كده.
Okay. So, unexplained, multiple family, sudden cardiac death, cardiomyopathy, so forth. There's genetic disease of some sort because, among multiple generations. And then we did genetic testing, and the results came back positive for DES gene mutation, which encodes for desmin. And desmin is a protein that provides strength and integrity to cells. And so the red lines here are representing desmin. So it just connects multiple organelles within the cells. Okay, so it's everywhere and provides integrity and strength to the cells. So as you can imagine, when that desmin protein is malfunctioning, the cell just falls apart. Okay, so mutation with des gene would result in many cardiomyopathies, but mainly dilated cardiomyopathies. And it's a rare cause of dilated cardiomyopathy. It's not a very commonly known mutation. And there might be associated skeletal myopathies as well. So in brief, like you guys know, so cardiomyopathies are divided into left ventricular non-compaction, arrhythmogenic cardiomyopathies, dilated cardiomyopathies, hypertrophic cardiomyopathies, restrictive cardiomyopathies. Okay, so with LV non-compaction, you want to see trabeculated LV. With arrhythmogenic cardiomyopathies, you typically would see predominant arrhythmias. With dilated cardiomyopathy, of course, there's dilation, decreased muscle mass. With hypertrophic cardiomyopathy, there's increased muscle mass. With RCM, there's stiffness and so forth. Okay, and then there could be familiar genetic causes and non-familiar causes as well. Okay, so with further subclassification of arrhythmogenic cardiomyopathy, you can divide them into dominant right ventricle, dominant left ventricle, and biventricular. I will not go into details, but of course, everyone heard of ARVC in the past. There's ALVC form, there's biventricular form, and so forth. Okay, and there are specific gene mutations that would result in LV disease, and specific gene mutation would result mainly in RV disease. Okay, so remember, with arrhythmogenic cardiomyopathies, these are muscle disorders, cardiac muscle disorder with high burden of arrhythmias, and genetic testing is the standard of care. And again, if you want to know more about desminopathy, there is also, we did present this case in the past. Okay, so these are examples of cardiac muscle diseases that are unexplained with positive family history, ECG, imaging confirming muscle disease and arrhythmias. So genetic testing is the standard of care. Okay, so anything that's unexplained in young individual with multiple family members, you always think of genetic testing. Okay, so case 6. This is the last case. So 15 years old girl with sudden cardiac arrest, unprovoked. She was asleep at the time. She had a paternal auntie and uncle with sudden cardiac death. I don't know the exact details. They passed away many years ago. She had an echo which was normal, but she had severe brain injury. Okay, so she presented to Mubarak Hospital, I think, or Mubarak, yes, with vegetative state, like brain death. So she passed away soon afterwards. Okay, so this was her ECG, and nothing remarkable about that ECG. Like there's nothing that immediately pinpoint to a specific diagnosis. Okay, you agree, guys? So now we know there is. She's young. She had sudden cardiac arrest. There's something it's unexplained. So obviously, genetic testing should be done. But she passed away soon afterwards, so we were unable to do genetic testing for that patient. But knowing the paternal family history of sudden cardiac death, obviously we want to test that. We will focus on that. So we did that. This is dad ECG at rest, which was also remarkable. But we did genetic testing for dad, and it came back positive for SCN5A mutation, sodium channel mutation. okay, which might guys, you can hear me, right? Right?
Yes, yes.
Okay, which might result in Brugada syndrome. But there's no Brugada in the father, at least, or in the patient that died, that passed. But there's a provocative test for patients with possible Brugada that we can do that might show or manifest Brugada ECG. And we can give sodium channel blocker because this is a sodium channel disease. If you give sodium channel blocker, that sodium channel disease would be more obvious. So we gave flecainide to the dad, IV flecainide, as a challenge for dad. And then look what happened. So this is after IV challenge test. Look at what happened to the dad ECG. What do you guys see?
Brugada syndrome.
Yeah. So dad had manifestation of had Brugada ECG post flecainide challenge test with a CN5A mutation, which is a gene known to cause Brugada. So obviously we suspect his daughter, death was secondary to Brugada while asleep, especially. But so that's our suspicion, and that's that's a case of Brugada that I met a couple of years ago, like last year or so. Okay, so with Brugada, there is a specific ECG pattern that you want to look for to diagnose Brugada. In order to diagnose Brugada, you want to see ECG positive for Brugada. Yani, I do have a patient family who had genetic testing with normal ECG, and they had hypertrophic cardiomyopathy phenotype. They did genetic testing, came back for multiple mutations, and one mutation was weakly associated with Brugada, and they labeled the family as a Brugada family without any Brugada manifestation. So you want to, in order to diagnose Brugada, you want to have ECG, classical ECG changes, okay? Not genetic testing. You want to, for Brugada, it's a clinical ECG diagnosis, okay? So you want to see type 1 morphology ECG, okay, with more than 2 millimeter and more than 1 lead ST segment elevation in the right precordial leads, okay? طبعا usually we position them high in the chest, either spontaneously or after provocative test, okay? Okay, so there's no, and you cannot diagnose Brugada otherwise. You need to see ECG changes, okay, guys? Okay. And Brugada is, some people classify Brugada as channelopathy, some people classify Brugada as cardiomyopathy. It's probably both. And remember, Brugada is very challenging to diagnose. So you might need to position the ECGs high on the chest. You might need to do provocative testing to see that Brugada pattern. Plus, genetic testing is only possible among 20 to 30% of the Brugada families. So the genes for Brugada are not super known, as probably multifactorial as well, okay? So I presented 6 cases in adults, because we're focusing on adults with inherited arrhythmia conditions that are rare and challenging in general to manage. Whenever you encounter family with sudden cardiac death, unexplained syncope, LV scarring, and so forth, you want to include inherited arrhythmia specialist, okay? You want to include cardiac geneticist, okay? You want to do extensive family screening for at-risk family members. In general, I always encourage the families to do BLS training, maybe purchase AED, for some specific families, and the genetic testing should be done, and after it's done, should be very well analyzed, and then the genetic testing very often informs your management. So there's specific management per disease, per genetic mutation in general. There are sometimes drugs to be avoided, for example, for Brugada, for long QT syndrome. You want to look up drugs that should not be used for Brugada or long QT syndrome. And then there's sports participation considerations depending on the specific channelopathy or cardiomyopathy that you are encountering. Okay, so sorry for what happened, guys, in the middle, interrupted our flow. But so like I said, let me just stop recording before I keep going.